Okay, I think we will start. I hope I'm audible. Okay. Good evening, everyone. Respected Dr. Amit sir, members of the Safe Dental Updates, and dear doctors. We welcome you back for our 33rd episode of Learn from Our Master series, organized by Safe Dental Updates. And it's been a beautiful journey so far. And I thank all the doctors who have been attending our webinars and also visiting our platforms like Instagram, Facebook, and YouTube channel. And very, very humble to see your positive feedbacks. So for those who have been attending our, for those who are attending our series for the first time today, I would like to do a little bit of introduction about ourselves. We are Safe Dental Updates, a dental platform in which we believe quality education always ensure predictable outcomes for dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. We conduct various webinars and workshops to enhance the skills of dental professionals and guide your dental journey. So without further ado, let us start our series in which our topic of discussion is impressions in removable prosthodontics, given by Dr. Amit sir. To speak a few words about him, Dr. Amit sir is a prosthodontics from Mumbai who is mainly practices the specialty at his private practice. He's a certified professional in cast partial denture techniques from Bego, Germany, full arch implant prosthetics from AIC Ostam Academy, South Korea, suction effective mandibular complete denture protocol from JPDA, Japan, and most recently, BPS complete denture from Ivoclar Vivended. With practicing experience since 2007, he has a solid foundation of both the theory and application of the specialty, especially towards removable prosthodontics and implantology. He has lectured and conducted workshops on various topics throughout the country, and also a technical guide in cast partial denture technology to various labs in India, with workshops conducted in Maharashtra and Gujarat. Moving ahead, with his experience in teaching the subject of removable prosthodontics, he has now been a mentor to many practitioners across the country. So without wasting more time, I would like to invite Dr. Amit sir for today's discussion. Sir, please.
Thank you. Thank you very much, Dr. Shanu. Am I audible to everybody? So probably, Shanu, if you can give me a thumbs up.
Yes, sir.
I'm audible.
Yes, sir.
Great, great. So it's great to do webinar and connect with everybody all across the country. And I mean, I'm really amazed by a lot of younger individuals coming and forming groups on social media and having a very powerful reach all across the country, or not only all across the country, all across the world. So the topic for today is impressions in removable prosthodontics. I'll start sharing my screen and let's discuss a lot of things in detail over the next 1 hour. All right, I hope the screen is visible.
Yes, sir.
All right. Okay. Great. So, starting with the topic today, I wanted to choose something which is absolutely basics of prosthodontics. Be it fixed prosthodontics or removable prosthodontics. When it comes to making an impression, that lays a reliable foundation, for a prosthesis. Dr. Shanuf, I am unable to move ahead with my presentation. So let me just share it once again. Okay?
Okay, sir.
All right, so it looks good now. So what we need to do is we need to lay a reliable foundation for a prosthesis. All right. And especially with removable prosthodontics, this has been my experience over the last few years that a primary impression to start with, in case of a complete denture, for example, has got more importance than a definitive impression or a final impression. So, a primary impression rather lays a very strong foundation and on which a custom tray is fabricated. And then we move ahead with our definitive impression or the final impression. So, a very heartfelt greeting to everybody who has been fasting throughout the month, and Eid Mubarak to everyone. And if you, if you really ask something from the Almighty with, all your heart, you certainly get it. This has been my experience, and I'm sure it is everybody else's experience. So to you and your family, Eid Mubarak. This is me. I'm from Thane. Thane is a suburb in Mumbai. And I have a practice called as Care Dental. I'm practicing here since about 15 years now. Time flies, and I started with my practice first and moved on to my master's later. So we have recently moved to a slightly bigger place. That is where I'm sitting right now in front of you all. And the earlier practice was a modest 2-chair practice. We have a slightly bigger practice now, and we try to focus more on prosthodontics and periodontics. All right. So okay. So I really cannot believe BPS has now completed 25 years. For all those people who do not know what BPS is, it's a short form for biofunctional prosthetic system, and it's a proprietary system from Ivoclar. And I really cannot believe it's been 25 years altogether since BPS was first launched in the late 90s. And it's an alternative system for complete dentures to start with. Ivoclar uses its own proprietary products, and it makes the life of the operator as well as the patient much more easier, especially for those people who are new denture wearers. Not only new denture wearers, for those who are receiving their dentures for second or third time, BPS can be a much more comfortable system versus the other conventional systems. So I recently happened to receive a certification in BPS that was from Liechtenstein. It's a small country near Switzerland. That is where Ivoclar is based. And fortunately, I was with a couple of dentists from Kerala. And, we had a good small cohort who attended BPS. So today we not only focus on complete dentures, that is making impressions in complete dentures, we would also want to focus on a little bit of recording partially edentulous arches for a cast partial denture. So it could be for a cast partial denture, it could be for a normal acrylic denture, which is usually indicated for an interim prosthesis. All right. So we first start with complete dentures. We need to get our basics correct with complete dentures. Okay. When I speak about primary impressions in complete dentures, you need to remember one thing: impressions are to be made by the dentist and not the patient. All right. So it is us who guide the patient throughout the impression procedures. Patient is an active participant in only one area of the lower arch. Do remember this. It's the anterior alveolingual sulcus, whereby the patient would want to thrust the tongue ahead or put it onto their upper lip in order to record the lingual freedom. Rest everything, it is you who has to take a call on how to move ahead with the impression section by section. Now, with complete dentures, most of us are always worried about the lower arch. Believe me, if you follow a set protocol or a set of rules, you would definitely achieve the lower impressions with utmost ease and precision. We have two main materials which we use for our complete denture impressions. One of them is compound and one of them is alginate. Okay. Compound, as we all know, is a more mucocompressive material, whereas alginate is a more mucostatic material. It does not compress the tissues all the way. And if you carefully see, alginate would record the underlying details with much more precision than compound. Compound is a bulk material. Compound is a gross material. All right. Also, I would indicate alginate in those impressions whereby there are undercuts, typically on the lingual aspect. We all know that mylohyoid ridge is a very sharp ridge on the lower lingual aspect. In the upper arch, the areas around the tuberosities might have a severe undercut sometimes. So you can use alginate in that scenario. See, I'm not saying that compound is to be completely discarded for your completely edentulous arches. It still is a very valid material, because the major advantage with compound is that you can heat and reheat the material and introduce back inside the intraoral cavity for achieving better borders, more precise borders. So I have been slowly moving on to alginate. This has been a very gradual transition. Single mix alginate of your favorite brand can be used. I will also tell you another way in which you use two alginates and then mix them simultaneously. But single mix alginate to start with is a wonderful material, but you need right trays for that. We'll discuss those trays in the slides to come. Now, this is a dual stage alginate in which one of the alginate is inserted inside the syringe and the other alginate is inside the tray. So we have a tray alginate, which is a little more firmer in consistency. And we have an alginate, which is a little more runny in nature, okay, with a lesser viscosity, which can be put inside the syringe and you can inject it all over the vestibule to record the primary impression. Okay, and this was first produced by Ivoclar way back in 90s. Unfortunately, Accudent XD from Ivoclar is no more available because of some regulational aspects in Europe as well as in Asia. So Accudent XT is no more in production, but the earlier material which you saw is from Cavex. Cavex is a Dutch company which is available in India as well. If you all want, I can share the details of those dealers who are taking care of the supplies with Cavex. Moving ahead, this is medium fusing impression compound. It is still a gold standard, just as I said in the earlier slide. Compound can be reheated to achieve those precision margins, which sometimes might not be possible with alginate, because what you're doing is you are hurriedly mixing the alginate and putting it inside the patient's mouth, probably not giving due consideration to rolling the borders and getting that adequate amount of record of the vestibule, the right amount of record of the vestibule. All right. Primary impression in case of highly resorbed ridges can be done with a more developed technique. Well, it's not a newer technique. It was explained way back from an author called Stewart, in which we first record the impression using an impression compound. So you will have to use a tray which is indicated for usage of impression compound. And then what you do is you go ahead and scrape the intaglio surface of the impression. Do not touch the borders here. All right. If you touch the borders, you will lose the adequate extension. And then what you do is you mix the alginate a little thinner and then you layer it all over. So that's a second step technique. So it's a two-step technique. All right. Just like your two-step putty wash technique. All right. Of course, it goes without saying, people are now moving towards digital technology. You can use intraoral scanners to record the edentulous foundation. But believe me, it is still a dual process. It is not exclusively digital in nature. You have to go ahead and make or register a definitive impression using analog techniques. So it's like a hybrid model still. We still haven't gotten completely towards digital dentistry. And recording primary impression is possible because what you are doing is you are recording the anatomical impression. A primary impression is more of an anatomical impression. You can also call it as an overextended definitive impression, right? Yeah, that's what I was speaking of, right? A primary impression is always overextended in nature. We need to cover all the landmarks and register a slightly overextended impression so that you are able to mark all the landmarks after receiving a primary model or a primary cast, and then you can fabricate your custom tray on the primary impression, on the primary cast, and then move towards your definitive impression. All right. So it goes without saying, a PI is an overextended FI. Yeah. Moving ahead. If you register your impressions with alginate, you need to get well-rolled borders in order to make a great foundation. Also remember, you need to record important anatomical landmarks. What would those be? When we consider the lower arch, it is the retromolar pad, which is a very important landmark in the lower arch. If you do not cover retromolar pad, you are losing on your primary retention. Retromolar pad has been classified by a lot of textbooks, a lot of authors out there as a primary retentive landmark. All right. So what you do is, in order to achieve maximal amount of retention, you need to register retromolar pad. Not only register it, if you are able to see it in your primary impression, go ahead and mark it with a marker like a hematoxylin pencil. Now, the one which I normally use in my practice is the one which you get from Stedler. It's called as Stedler Luna. You just mark your retromolar pad, and then are you able to see it over there? And only then you will be able to see it on your primary cast. The marking would get transferred onto your primary cast. All right. Also, do remember, before you are moving ahead with your fabrication of custom tray, you need to go ahead and map your primary model. Only then you will be able to fabricate a good quality custom tray, a well-extended custom tray. Now, these are those trays which I have been using. They are from Ivoclar. They are called as the Accudent system altogether, along with the alginate. Unfortunately, again, Ivoclar has stopped producing these trays, but don't worry, we have something called as extent trays available from Delta. Now, Delta is an Indian company. It's based in Chennai. And you will be able to procure these impression trays from Vijay Dental. I can connect you with the person from Vijay Dental who can procure you these trays. I'm not promoting any particular product, but these have been a part of my armamentarium since quite some time. And for alginate, now, these are indicated for alginate. They have made my life much more easier. Okay. Now, if you carefully see the lower tray, with respect to extent trays, you have a very prominent sublingual arc. The sublingual arc is something which goes deep inside the sublingual crescent zone in the anterior alveolingual sulcus. So it's a primary retentive landmark. So you are starting with your retention right from the primary impression. Also, if you see the side view of these trays, it has a raise for the retromolar pad. All right. So it has a raise for the retromolar pad. What it does is, once the retromolar pad is recorded, okay, once the retromolar pad is recorded, you need some room for that retromolar pad. Okay. What you do is, typically with the resorbed ridges, retromolar pad is one zone which is not recorded completely. Okay. With the normal trays. With this particular tray, what it does is, it gives some room and that particular area can be recorded well. Moving ahead, you also have this gauge from the Accudent. All right. What it would do is, it would mark two widely distributed areas in a particular arch. The most widest areas are the maxillary tuberosity, and in the mandibular, it would be the retromolar pad. So what it would do is it would mark those two areas, okay, and you can then select your tray. Always remember, if you are in confusion, select the tray which is slightly bigger than the one which you have chosen, okay. Similarly, Extend also has a gauge, a similar gauge available, okay, and it goes without saying, you need to mark your PPS onto your primary impression. What you exactly do is you locate your PPS during the PI and then you transfer it onto your primary impression. All right. Even if it is the lower arch, if you see carefully, see there are two implants which are already placed in this lower arch. Okay. You still need to achieve well-rolled borders because majority of the brunt of the lower denture is also going to be borne by the distal extent of your lower denture. Okay. Now, FCB trays. This is something new. It is produced by Morita from Japan. Now, my major indication to use this tray would be to achieve something called as suction effective mandibular complete denture impression, which is also called as the SEMCD impression. It records the retromolar pad in an absolute undistorted way, all right? And what it does is, it gives some clearance on the retromolar pad. So there is no coverage on the retromolar pad. And what it would do is, it would record the retromolar pad in an absolutely undistorted manner so that you can rightly record the retromolar pad and transfer it to your PI cast. This has been developed by Dr. Jiro Abe. He's based in Japan, and he's also the proponent of the SEMCD technique, that is the suction effective mandibular complete denture technique. So moving ahead with the lower impression, in this case, what I have done is I have used two alginates in two different phases. Okay, and once the alginate is loaded inside the syringe, the orange one is the alginate which is loaded inside the syringe, and the blue one is onto the tray. You ask your assistant to help you out with mixing one of the alginates, and you inject the another alginate. Both of them are done simultaneously together. Let me just show you a video in which I have used the two alginates, okay, and recorded the upper arch first. Can you see I am able to roll it across the vestibule all over, slightly reflect the upper lip so that the alginate which is inside the syringe goes completely onto the vestibule and inject some onto the vault of the palate. You would want to inject this alginate onto the palate, especially in those cases where the vaults are too deep, okay, so that you do not have any void while recording the impression. Okay, slightly mold the areas so that the alginate gets into the nooks and crannies, and ask the patient to bend the head down. So once that is done, okay, your PPS will be accentuated. Now coming to the lower arch. Lower arch, the ridge is completely resolved. So once I move all over the buccal as well as the lingual aspects, it virtually fills up the whole of the mouth. Okay, and once it fills up the whole of the mouth, you then take your tray, you load the alginate onto the tray. Make sure that do not load too much amount of alginate. This is a bit more amount of alginate. Okay, then you put it inside and you mold the borders in the lower arch as well. Now, when it comes to selecting and modifying the tray, those trays which you have already used before in your colleges and the ones which are indicated for impression compound, they are a little crude in nature. They are not well shaped according to your edges. So what you have to do is, in order to use those trays, you will have to slightly crimp it and trim it. Typically, in the distobuccal region, whereby if you cut the area, you will be able to make some room for the mesenteric notch. Okay, the masseter. The masseter, the fibers of the masseter, they fall on the buccinator. All right, and in the resulting impression, the mesenteric notch will be seen. How would you want to record it? You put your fingers onto either side of the arch and ask the patient to close the mouth. So while closing, the masseter gets activated. So for that, you will have to modify such trays because they are not rightly contoured according to the underlying ridge. So what I usually use is an ortho plier or a heavy duty plier in order to mold these trays and make them more towards the ridge. If you don't do that, you will end up getting a slightly broader border. Now, typically in the lower front region, I might not have probably bent it too much, okay, and made it well adapted to the underlying vestibule. So in that case, you would land up receiving a wider border. This is usually my starting point. Okay, what I do is I put some material on the distolingual aspect first, okay, and then typically in the upper arch also. Sometimes if the palate is deep, I put some amount of compound. This is my first load. It acts as a stop in case of palate. And in case of lower arch, it would support the distolingual area. Now that's the area which is influenced by tongue heavily. So sometimes you might not get the record, but if you build up the compound first and then make a second load on top, you would be able to do that easily. All right. So in case of maxillary anterior region, typically try to orient the tray properly. Okay. If you try to orient the tray properly, all right, the label freedom should be right in the center. Okay. You would be getting a centered impression. And if you don't do that, sometimes you might land up in shortening the PPS from one segment. I'll show you those slides further. Also, make sure that your second load is absolutely wrinkle free. No wrinkles on it, no bends on it. Distribute the material uniformly on all the aspects. And this is how you will be achieving a primary impression using impression compound. Now, if you see the reverse side, that is the polished surface of the denture, also try to achieve some amount of polish on the other side of the tray, okay? So that you don't have chunk of compound left over there. Trim it with your cutter, you heat it again, and you place it back inside the patient's mouth, okay? In the upper arch, you need to mark the PPS. It goes without saying. What do you typically understand with PPS? What are the typical dimensions of PPS? Let us have a look at that. PPS is a little broader on the either side of the midline. Okay, in midline, the PPS is very thin. Okay, and PPS is slightly broader on the lateral aspects. Okay, right behind tuberosity, if you see, PPS is again a little thinner. So what happens is you get a Cupid's bow appearance of PPS all over because of these anatomical variations. Some people ask me, where do fovea palatini lie? And does that really have any significance? Well, in some cases, fovea palatini does lie about a millimeter ahead of your posterior vibrating line. Okay, I would definitely want you to show, see PPS sometimes live the way I mark it. Okay, but over here, I can probably show it to you through some images by utilizing something called as a T-burnisher. What I normally do is, the T-burnisher is a Y-shaped instrument. Okay, you just lodge it onto one side behind the tuberosity. Okay, now that is what is called as your pterygopalatine seal or the pterygomaxillary seal. And then you move towards the other side and you start moving medially. Can you really see there is a stark difference in the color of the tissues on both the sides, on the anterior as well as the posterior? You will be able to see that faint Cupid's bow line. Now that is the junction between your compressible tissues and the firm tissues. Okay. Right in the midline, you have the PPS at its thinnest. And then again, when you move laterally, the PPS will slightly widen. All right. So this is how you map the PPS. This is called as mapping or palpating the PPS, the compressibility of PPS, and then transferring it into your complete tension for better retention. Now, in some cases, you need to mandatorily mark the PPS because the ridges are a little thinner. I had typically faced a lot of issues in this particular case. Okay. And then what you do is you mark the PPS. Okay. Once you mark the PPS, you go ahead, you will be in a better position to transfer it onto your primary impression. This is how you do it. Slowly and steadily with your T-burnisher, keep on palpating the tissues and keep on with your marker, corresponding area needs to be marked onto your junction between the hard and the soft palate. This is how your PI is. And then you put it back inside the patient's mouth once you have marked it. You will get these smudged areas, but then you refine those areas before you pour your impression. So once you pour your impression is moist, and that's how your marking gets transferred onto the model. Always remember, PPS is not just a line, it's a zone. You need to mark the whole zone. By doing this, by marking only a single line, you might make the patient devoid of that additional retention which he otherwise would have received. So PPS could be way back, the posterior vibrating line needs to be at the junction of those tissues which move a lot, the soft palate areas which moves a lot and those areas which move mildly. Okay. So your posterior vibrating line might lie a little bit on the soft palate. Always remember this thing. Okay. And this is what I was talking about when I asked the patient to bend the head down. Okay. What you do is you correspond to somewhere about 30 degrees to the Frankfurt horizontal plane. Okay. Now, how would you cast the impression? How would you pour the primary impression? You go ahead and pour it. I use the inversion technique. Use your platform for the base. Okay. And then don't forget to go ahead and cut the ledge area. All right. You need to cut the ledge area. This ledge or the land area is very important because it's like a Lakshman Rekha to your vestibule. Okay. To the vestibular area which you have recorded. Well, you put a lot of time in recording that area, isn't it? Similarly, in the lower arch, on the lingual aspect, do remember that don't keep the tongue space too higher. Cut it off. You need to cut it off and you need to make some more room in order to register each and every area. Typically, the mylohyoid ridge, you need to be able to record the mylohyoid ridge and locate that. Okay. So this is how your primary impression looks like, and then you start mapping the primary impression. Moving on to the final impression. Okay, you need to take into consideration the spacer design, and then you fabricate the custom tray. I normally use the material which is more easier to use. It's called as the UDMA or urethane dimethacrylate for fabricating my definitive trays. Okay, you can use PMMA also. You can use the tray material PMMA. It's a little difficult to use and you might not be able to achieve those thinner areas. I would show you a few images now on how you can make your custom tray using lighter tray material. All right. Always remember, a definitive impression is just the replica of your denture. Your denture is, in fact, the replica of your definitive impression. No shortening of borders, no trimming of borders. Your borders need to be just like your definitive impression borders. So in the case of lower arch, even if you have registered your impression with a zinc oxide eugenol paste, okay, and you have done your border molding conventionally utilizing green stick compound or the low fusing compound, your final denture needs to be just like your border needs to be just like your FI. Okay. In the upper arch, what I do is I give some more relief for the rugae or the mid-palatine raphe region. Okay. Whereas in the lower arch, if you see, usually I mark the retromolar pad area, the buccal shelf area, and I do not provide any spacer to the buccal shelf area. You mark the mylohyoid ridge on the lingual. Okay. Now there is a set procedure which I follow to it. Probably at a later date, if I'm able to explain this to you in depth. Okay. But for now, do remember that your custom tray needs to correspond almost to your retromolar pad area, or in fact, just short of your retromolar pad, and you draw a line down. If you go beyond the retromolar pad area, you will be landing up into your throat. Okay, and the patient will have difficult time in swallowing anything. Okay, it would hurt the throat. This is how you mark the area. Now, the blue zone, if you see, that's typically the spacer region. Okay, your custom tray in the anterior region needs to be about a millimeter beyond the spacer. Okay, this is how. Also, make sure that you cover the mylohyoid ridge. Okay, a little beyond your mylohyoid ridge should be your spacer. Okay, so that your custom tray does not keep on scraping this sharp anatomical landmark. Okay, no spacer on the buccal shelf area. You know why? Because buccal shelf area is more of a horizontal area which can take up a lot of load, the masticatory load. So you would rather want to slightly compress the area in that particular region, so no spacer. Okay, this is how your spacer cutout looks like. And then once this is done, also make sure that you cover the retromolar pad. Now there is a school of thought which does not cover the spacer onto the retromolar pad region. Okay, because they would want to compress the retromolar pad. I would want to give some material space. So I usually cover the retromolar pad with a very thin spacer. This spacer thickness is usually about 0.5 millimeters. Okay, you make the lower handle in accordance to the lower lip. Never bend the lower handle ahead. In case of upper arch, you need to slightly bend it in the anterior region according to your lip contour. Okay, this is how your custom tray looks like. It needs to be well finished. Also make sure you are actually looking into those finer details and giving some more room to the lingual frenum, for example. Okay, so one more specification which I would want to discuss for the mandibular arch is sometimes you should be giving the rests onto the posterior region. Always remember, if you give the rest, your finger will be right on the top. It won't distort your tongue and the buccal mucosa while you are recording the impression. Okay, you would want your buccal mucosa and your tongue to actually come close to another so that you get maximum amount of retention possible during the final impression. Okay, so stops or no stops, I think a lot of colleges have discussed this with you in detail. Sometimes a lot of people believe in giving the stops, but are they really a boon or are they a bane? You know, you need to have stops, but then you need to expose those stops. Sometimes not all stops are exposed, something like this. You know, sometimes only 2 stops will be exposed on one side and 2 won't be exposed. You need to expose all the 4 stops. Okay, so I really do not prefer giving stops nowadays because, you know, they would rather exert more amount of pressure into those areas. Okay, so I would want to be without the stops. So now this is how your custom tray looks like. Sometimes I add some amount of material onto the PPS region in order to compress the PPS. Now this custom tray is the UDMA material. One of them is from Voco. It's called as Individual Lux. All right, so this is Individual Lux. And then what you do is once you are done with your border molding all over, and you have also recorded the PPS, you put 4 holes in the anterior region. This process is called as venting. Okay, what it does is it distributes the pressure all over the palate, and you have some escape holes so that you also do not get any voids onto the palate. Okay, and this is how your final impression would look like. Moving ahead, there is something called as one-step border molding. Now, the one which I showed you earlier was the one with green stick. Okay, that's a sectional border molding. All right. Now, this is one-step border molding. Okay. If you carefully see, I have utilized a very soft putty. Now, this putty is from Detac. It's a, the company is called as Detac. So you put the one-step border molding material all over, also onto your PPS region. And then what you do is you make a wash impression utilizing a light body. Now, this is different from your sectional border molding, which is done using green stick. Okay. Now, BPS uses the hard, the one-step border molding using heavy body. Okay. So you have different phases. Now, this I would classify as a softer putty, but you can also use a heavy body for recording the borders. This is now PPS in case of the definitive impression is usually recorded by putting green stick at the back. You locate the PPS during your PI and you record the PPS during your FI. Now that's what the difference usually is. Okay. Now pterygo maxillary seal. What do you mean by pterygo maxillary seal? It's this particular zone. It is also a part of PPS. And sometimes you need to put a little more material near the lateral region to the tuberosity in order to locate that region. And once you put the material, when the material is soft, you ask the patient to move the jaw sideways, something like this, so that the material goes into that area. In some areas, the pterygomaxillary seal might be a little underdeveloped. Okay, can you see the contrast on both the sides? So probably in some scenarios whereby you are extracting the third molars and you'll end up fracturing the tuberosity in that region. So what you actually do is, once the tuberosity is fractured, you might not get that, that bulky nature of the tuberosity, but still you would be able to locate the pterygomaxillary seal, and then you complete the border all over. Okay. Now, moving on to something called a scraping of the master cast. If you have recorded your PPS well, still if you do not have a good amount of retention during your record-based stage or the jaw relation stage, what you do is, utilizing a burr, you slightly reduce the cast with the burr. Of course, that is a little arbitrary in nature. That's why it is also called as the arbitrary scraping of the master cast. Do remember, do not go more than about 0.5 millimeter in this zone. And then that zone will be covered in the denture, which will have a little more positive contact with the PPS and help you in achieving some amount of retention. Okay. Now, if you move on to this particular case, can you see the midline is slightly shifted? Can you see the incisive papilla is a little offset? I noticed this while I was recording the photographs. So I thought that let me go back and check the FI. We had a similar issue in the FI as well. All right. Not only in the FI, when I moved back to the primary impression, the PI also had a similar issue. What it was doing is, it was not recording the PPS adequately in one particular zone. And the mistake was during the primary impression, whereby what had happened was, I did not center the tray. You remember I showed you a slide earlier in which the centering of the tray was not done rightly. Okay, the incisive papilla was slightly offset to start. Okay, so do take that into consideration. Let me just show you a few images what exactly happens in the final impression of the lower arch. In this case, you make a PI, you go ahead and make the custom tray. Okay, I have utilized I have utilized the poly tray from Delta in this case. Okay, and then sometimes what I do is, I keep the thickness a little more broader in the lower anterior region, in the alveolingual sulcus region. Okay, what it does is, it actively records the lingual frenum. Okay, and it gains a little more thickness and covers that undercut region of the lower anterior alveolingual sulcus. The rest of the areas can be as thin as possible, which would be covered with the green stick. So you start molding utilizing the green stick. First on the distobuccal segment, then on the anterior, and then on the distolingual segment, distolingual on the other side. Sometimes while putting green stick, your green stick might go onto the tissue surface. Always remember, cut that area off. You need to cut the area so that, that area of the ridge, typically those undercut regions are recorded with the light body and not the green stick. And this is the completed border molding. Now, I've utilized a ring flash over here. If you carefully see, my flash is on the green stick. Okay, but do remember that your green stick does not need to be glossy. It should be matte in appearance. And that would be an indication that you have molded your green stick nicely. Your green stick has contacted the vestibule nicely, and you are achieving a matte finish, a matte texture on your border molding. Now the spacer wax is removed, and then you make your completed final impression. Let's take a recap. 1, 2, 3, 4, 5, 6, and then 7. All right, let's move ahead. One-step border molding is a part of the BPS protocol. As I explained you the BPS earlier, what it does is, it utilizes the definitive impression and the jaw relation and registers in the same appointment. Now, this is a combination method which I have utilized Okay, I've utilized rims in this. I have gone ahead and recorded the jaw relation. I have optimized the vertical dimension, then done a one-step border molding and made a wash impression. And in the end, I have recorded the centric relation and sealed it with aluvax on both the sides. If you carefully see, there is a disadvantage here. You might land up, sometimes you might land up increasing the vertical dimension. Okay, can you see the aluvax coming in between those two rims? Not only that, sometimes the borders all over might interfere at the back, typically near the heels region. Okay, so sometimes this particular technique is not rightly indicated in those cases where you have lesser amount of interocclusal clearance all over. So do not use this technique then. You can also do this by recording the Gothic arch utilizing the needle point tracing device. Now this is a BioTracer from Delta. It's again a make in India product. Okay, and you record the upper and the lower impressions, and then what you do is you record the jaw relation utilizing bite registration material. This is addition silicone bite registration material. Okay, probably at a later date, sometimes if I have an opportunity to interact with you all further, I would want you to see how the Gothic arch tracing is done and how you go ahead and record the upper and the lower arches together. Now this is BioTracer. You have this spacer device, which is then replaced with the metal plate, the flat metal plate in the upper arch, and then there is a pinpoint needle tracing device in the lower arch. Can you see that arrow? We have marked that arrow and we have located the centric relation. So this is called as the point centric relation. You may not be able to achieve this utilizing your wax rims. Okay. Now this is your tracer in centric relation. Okay. Can you see we have logged that position, and then with the bite registration material, you go ahead and record it. Let's move ahead. In the lower arch, what if your ridge is a little flabby? Okay. What if your ridge is a little pointed? What you need to do is you need to relieve the stresses. So in the conventional method, what you do is you go ahead and record your jaw relation. Okay. Once you have recorded the jaw relation, okay, what you do is you go ahead and put some holes on top. Okay. So that there is less amount of pressure which is exerted onto the underlying ridge. And I have used Aquasil Ultra over here in the lower arch. And then that is basically, it's nothing but ultra light body. It is not even light body. Instead of this, you can also use the Zermax Hydro Rise. You know, even that has a slight bit of characteristic ultra lightness versus the light body. Okay. And then the ridge can be recorded in an undistorted form. Otherwise, you might land up pressurizing the lower ridge and your ridge might distort. Okay. Now, in case of upper arch, okay, I have utilized a two-step procedure over here. Carefully look at this, whereby I have used two different materials, one for your normal ridge and one for something called as a flabby area. Now, typically what happens is in certain scenarios, you have a flabby ridge or unemployed ridge in the upper anterior region. Okay, the tissues are a little flabby. You can actually move them, and there is some amount of inflammation as well. Okay, typically in the upper anterior region. Now, this patient is already a denture wearer. If you carefully see, it also has, the patient also has some amount of inflammation in the vestibule, typically in the anterior vestibule. So what you do is you first record the PPS, you make your primary impression, okay, and then what you do is you pour the model, you mark the anterior region. Okay. Now, typically for the spacer, do not give the spacer onto the PPS region. Okay. Never give a spacer on the PPS region. And then give a double layer spacer over the flabby tissue. You can actually add a triple layer of spacer. All right. Then what you do is you make the custom tray. Can you see what I have done is I put the handle right in the center of the palate. Okay. Do not put the handle in the anterior region, because what I'm going to do here is I'm going to cut off that region after making the first step impression. Okay. Now, if you see the thick buccal freni, you need to, everything goes just like the plan, just like you have done it for other cases. You relieve those areas, okay? You house the freni, okay? So that you can record it with the green stick. You complete the border molding, you make those holes, and now I have made my wash impression utilizing addition silicone monophase. I'll come to monophase, what exactly monophase is, okay? And it's available from Dentsply under the name Dentsply Aquasil Ultra, okay? And then what I have done is I've cut off that region near the flabby tissue, okay? So it's like a two-step technique which I'm using now. Why? Because I don't want to record the flabby tissue under pressure. I need to record the flabby tissue as mucostatic as possible. What you do is you position it, you cut off the window, and you actually take into consideration all the areas. Rather, I would suggest you cut something extra as well. And then you inject light body over the addition silicone monophase. Okay. Make sure that your light body and monophase are merging together nicely. Okay. Moving on to partially edentulous arches. Okay. Now, when you come to recording impressions for your cast partial dentures or for your normal acrylic partial dentures, what you do is I still would go ahead and record the impression for the distal extension area where there are no teeth. It is edentulous in that segment. I do the border molding, and in those areas where I do not want the border molding, typically the mandibular anterior region, okay, I would just record it with the monophase. How do I make the custom tray for this? I'll show you. In case of the partially edentulous arches where the teeth are present at the back, you do not need a custom tray. Just like the image which I showed you earlier. You can register your impression utilizing the two-step technique. You can put a thin layer of cellophane sheet on top, okay, make your putty impression, and then make the wash impression utilizing the light body in the second step, okay. Now, in distal extension scenario, on the other hand, what you do is you go ahead and make the custom tray. So it's like you are making a hybrid impression, one for the partially edentulous arch, okay, so that will be just like your completely edentulous arch, and for the dentulous segment as well. In this case, I put stops both on the ridge as well as the teeth. So you put these stops so that your tray gets oriented while recording the impression, okay. This is what we exactly do. Now this is an image from one of the textbooks. If you see, that stop is touching the teeth, and that stop is also touching the ridge, and it is creating some space for the impression. Okay, now we are talking about the partially edentulous arches. Remember, if you want to record a perfect impression for partially edentulous arches, you need to distribute the pressure also on both the segments, that is the dentulous as well as the edentulous segments. Okay. Now, for the upper arch, if it's a distal extension scenario, I have made a similar custom tray, okay. And for the dentulous areas, I have kept some more room. So you put some more spacer wax onto the dentulous region. Can you also see I have created a small rest seat for the cast partial denture, and I have recorded it. Now, addition silicone monophase is indicated in this case. And why is it indicated? It's because, as I told you, for a partially edentulous arch, you have two different types of supports. One is the edentulous ridge, which can compress more. One is the dentulous area, which compresses a little less. So you need to optimize the pressure between both the areas. Okay. So that's the reason I have used addition silicone monophase impression. It has a property called as thixotropy. Okay. What it does is once you mix it, it stays in a particular zone. And once you load it onto the tray and pressurize this, you put a little bit of pressure while inserting inside the mouth, it flows evenly all over and distributes the pressure all over. Okay. Now, sometimes you have fixed prosthodontics along with partially edentulous arch. So you are doing a combination of crowns as well as a cast partial denture. So what you do in this case is you go ahead and do your coping trial for your dentulous segment. Okay, you're going to put the crowns on the anterior region. Okay, so you go ahead and do the coping trial and you pick these copings inside your impression. You do the border molding for the rest of the segment. Okay, because your denture flanges are going to come in the posterior region. Okay, and then you go ahead and make your cast partial denture and the fixed partial denture together. Okay, in association with one another, so that the technician is able to match the aesthetics proper. In certain scenarios, this might not be the case. You go ahead and fix the dentulous segment first, that is the crown and bridge first. So once you cement that, and only after cementation, you go ahead and make an impression for your cast partial denture. Okay, but if you are doing precision attachments together, you have the anterior dentulous segment and you have taken a metal trial for it. You also have the precision. In those cases, you will necessarily need to go ahead and make a hybrid cast. That is, go ahead and do the dentulous as well as edentulous segments together. Okay, I hope I am able to justify a lot of explanations which I need to do over this short period of time. Okay, so I have tried to cover the primary impression in the complete dentures, the definitive impression in the complete dentures, and also to some extent, how would you go ahead and make a custom tray for the partially edentulous arches and register it with green stick as well as monophase. Okay, I leave you with a video of the case which I showed you earlier. Okay, can you see the flabby ridge in the upper anterior zone? There is no bone support at all in this segment. Okay, you can actually with the mirror check for the flabbiness. So now I have made my first stage impression already. Now what I'm doing is I am with a gun injecting light body all over. Okay, onto the flabby areas. And you remember we had to cut that window over there. Okay, so you inject it all over, and what you do is you take your monophase impression which you have made on a custom tray along with the window, and then carry it onto the area. And then you see the handle. Now, do you understand why the handle was made right on the center of the palate? Okay, you put it inside. All right, you register the orders again and make sure that you are putting adequate amount of pressure. Don't over pressurize it. Put adequate amount of pressure. Hold it. Hold the handle. So that handle will also now act as a rest for you. You inject the light body. Okay. You mold the areas well. Don't worry. Light body will support itself. Will support on its own. Okay. I hope you have a good internet connection and you are able to see this video clearly. Okay. And that's how you go ahead and remove the impression. Okay. That's how your impression will look. All right. So there are a lot of smiling faces going out of the clinic, especially when you dedicate yourself to doing good quality removable prosthodontics. Patients are happy. Okay, I know when it comes to removable dentures, sometimes we are a little reluctant in providing, and we convert the scenario into a fixed full arch treatment, for example, or you would want to give bridges in case of partially edentulous arches, or place implants and just forget what you have done. With removable dentures, probably you'll have to follow up the patients a bit more. Those patients might come back to you again and again, but in the end, it's it's worth it. Believe me, it's worth it. It's a longer journey. Okay, and all you need to do is just make them smile and let them go out of your clinic smiling. Okay. Now we are into workshops for removable prosthodontics. Well, rather it has been exclusively for removable prosthodontics till date. Just concluded a workshop last week, which was held at Precision Dental Studio in Thane. Now, Thane is a suburb of Mumbai, and had a good interaction with 6 or 7 dentists all across the country. There were people from Sikkim, there were dentists from Jaipur, Pune, and earlier this year in the month of January, the batch was even bigger. So there were people from all over the interiors of India, and I would love to interact with you all someday. Okay, if you would want to connect sometime and do interact with me on this workshop so that I can discuss in detail, in depth with you. Okay, so thank you so much. I'm now open to some questions. I think Dr. Shanuf, you have probably had a look at a lot of questions. So let me also have a look at the chat.
Yes, sir. I'll try to read out each question, sir. And if any queries are there, please do post your questions in the comment section. So we'll rectify each one of them.
Absolutely. I'll try to answer as much as possible. And still, if you have some things coming up, any cases coming up, do connect with me on Instagram or on YouTube. I've been posting some videos regularly on YouTube. It's been some time I haven't posted, but it's a continuous process. As and when I see something unique coming up in my practice, I document it, I record it, and put it up on YouTube. Yes, Dr. Shanuf, please go ahead.
Okay, sir. I think we have few questions here, sir. So I'll read out one of the questions. Which light body materials is best for the CD impression?
See, light body can be condensation silicone, it can be adhesion silicone. Now, both do the job well. With condensation silicone, one thing which I have noticed is the impression is a little runny in nature. You'll end up getting everything in wash, and you'll end up exposing the green stick too much. Okay. Sometimes what happens is you might not be able to adequately record the borders using green stick. Okay. So the deficiencies should be rather covered with the light body, and you should be able to get a perfect seal all over. So adhesion silicone is also all right. Choose the material which works best in your hands. Believe me, there are a lot of practitioners which are still using the ZOE paste for recording their wash impressions, and they are doing perfectly fine. It's just that adhesion silicone can be stored a little longer. If you send your impression to the lab, and if there is a lot of time which is elapsed in between, the adhesion silicone light body might do better versus the other two materials. I hope I'm able to answer this question.
Okay, sir. So what is the material for the single step border molding?
Yes, so I showed you a couple of scenarios. Single step border molding can be done using soft putty. Now, the material which I had used, the orange material which I had used was DTAX. It's DataSeal from DTAX, DataSeal function. So the name itself suggests that it will give you a functional impression, okay, utilizing a soft body, in which what you do is you mix the base and the catalyst and you load it inside the syringe. You put some tray adhesive on the border and you inject the material all over and you place it inside the patient's mouth. Also, you can register the border molding using heavy body. Heavy body is available from Ivoclar under the name Virtual. There is a material which I'm using recently from Delta, okay, from Vijay Dental in Chennai. It's under the name Bonacell. That's also a good material. There is a material from a company called as Huge under the name Perfect. So these are heavy bodies which you can use. You cannot use monophase for one-step border molding, mind you. You need a material which stays in the vestibule rightly and you're able to mold it. Also, it needs to have some amount of working time, setting time, isn't it? So that you're able to do some border molding yourself. You are able to trim the muscles nicely. Okay. So, yeah, that's pretty much it.
Okay, sir. So can you share a few points regarding about gagging reflex during impression?
Regarding gag reflex?
Yes, sir.
Well, yeah. So, one thing which I normally do once I meet the patient for the first time, I really don't know whether he's an active gagger. How would he respond to my impression? So one thing which I do is I always start with the lower arch impression first, and then go ahead with the upper arch impression, so that the patient is a little familiar with what you are doing inside your practice, right? Because see, sometimes you might land up loading more amount of impression material onto the tray. It could be alginate, it could be impression compound. Second thing, if you know that the patient will gag, so do not use alginate for the upper arch. Try avoid using alginate. Compound would be better material for the upper arch. Third thing, if you still want to do an alginate impression, if you want to record the tissues using alginate, using ivoclar or extend trays, load less amount of material, okay, typically at the back. Let the material slightly squeeze towards the soft palate and ask the patient to bend the head down. Ask him to look towards his feet, divert his mind into some, ask him to wiggle his toes. So these are a few things which you can always condition the patient and avoid the gag, So there is no foolproof way. It can only come by conditioning.
Okay, sir.
Yeah.
How to manage macroglossia patient for when taking a lower impression?
Yeah, so you know what? If you have a good primary impression, only then you will have a good definitive impression. Okay, what are the characteristics behind a primary impression? You need a good distolingual area. Now, with the patients who have a larger tongue, I would comment on this, that they would have a better retention versus those patients whose tongues are not filling the floor of the mouth adequately. But you need to have a good flange which records, because the tongue will have tendency to displace the impression material away from the distolingual region, typically the distolingual region. So you need to select the trays right. So that's why I am telling that the primary impressions need to be well recorded into the distolingual, so that you have custom trays which are made according to your primary impression, and only then your impression material will be supported with the custom tray. You will have something to go beneath the tongue and the ridge, which could be challenging at times with those patients who have larger tongues.
Okay, sir. So another question is, I think everybody must have faced this, in which our final impression can get a good extension and a good suction. But when it comes towards denture, final denture, the retention is lost. What could be the reason, and how to manage such situation?
That's a very good question. I'm telling you, even I have faced these issues time and again. It all depends upon the material which you are choosing. Now, there has been a huge debate that the green stick should not be used at all for registering your impressions. But believe me, if you have a good border molding done, okay, you also need to check whether your border molding has adequately contacted the soft tissues. You remember I told you that the matte surface needs to be checked. Wipe your green stick surface with the cotton, okay, and check whether you have extended your impression. You might get a false suction. Sometimes you get a false suction. You can get a suction with an underextended impression also, believe me. But your impression needs to be rightly extended, and you need to have a good suction. The debate which I was talking about is that a lot of people are now moving towards utilizing one-step border molding, because they believe that both the materials which are used, the final impression, wash impression material, and the one which you have utilized for your border molding, are made up of same material. So in that case, you will have better retention, and your denture also will be more retentive in nature. Okay, but I would still suggest you can still use green stick. Okay, a lot of people have started using very thinner mixes of alginate for their definitive impression. Okay, the green stick and then layered it with alginate. Okay, so then in that case, you are reducing the chances, but you need to pour your impression immediately with those materials which are thermoplastic in nature, which can be affected with heat. You need to pour those impressions sooner, and then you might not have such issues. You might have a good denture, a similar denture seal as you have received in the final impression.
Okay, sir. I think few more questions are also there, and some questions which are out of topic as well. I think we'll try to answer this question in any social media platform, since our time is very less right now. So we'll try to wind up this session.
Okay.
Okay, sir.
All right. So yeah, do connect regularly if you wish to go ahead and ask a few more questions. If you have any case or multiple cases which you need to show and discuss, feel free to go ahead and shoot me a message.
Okay, sir. Thank you so much, sir, for sharing your knowledge and expertise when it comes towards the impression in removal prosthodontics. And surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. Thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once again, thank you so much, sir, for this wonderful and
thank you for having me, and thank you for this opportunity to interact with a lot of people around.
Definitely, sir. We really appreciate your valuable time given for this series episode, actually.
Thank you. Thank you. Enjoy your Sunday, guys.
Yes, sir. And definitely, please do check out our sir's Instagram page where you can appreciate his clinical works, and do follow him in Instagram. And to know more about our upcoming webinars and workshops, please do check out our Facebook and Instagram pages. And those who have missed out any previous webinars, you can definitely visit our YouTube channel as well. And don't forget to subscribe. So once again, thank you all and have a great night, and Eid Mubarak to all.